The following presentation will be about pancreatitis for a group of Concepts 2 students for the elimination concept. So acute pancreatitis. Causes of acute pancreatitis are alcoholism, and alcoholism that is specifically associated to binge drinking, not alcoholism which is associated with everyday drinking. Cholelithiasis or gallstones causing obstructions of the biliary tract and the pancreatic duct can often cause acute pancreatitis, so gallstones can cause pancreatitis. Peptic ulcer disease, hyperlipidemia, hypercalcemia, and medications such as corticosteroids or prednisones, thiazide diuretics, and oral contraceptives. Patients that have hyperlipidemia are at a higher risk of having cholesterol gallstones. So assessment, we're going to have weight loss. Think about the labs that go along with weight loss. So we're going to have a decreased protein, a decreased albumin, maybe even anemia. Nausea and vomiting. Remember that your nausea sensor is in your head and not in your gut. So all of the antiemetics may have some type of CNS side effect. Pain. These patients have excruciating amounts of pain, and their pain is often right a midline. They often will call it a banding pain, so it goes all the way around their abdomen. It sits on the line between the right upper quadrant and the right lower quadrant. Hypoactive bowel sounds, they will have decreased bowel sounds. Left lung pleural effusions, for reasons related to osmosis. When the tail of the pancreas becomes inflamed, the fluid around the tail will often go into the pleural space in left lung. So left lower lung pleural effusion. So if we're looking for crackles, shortness of breath, and crackles in the left lower lung and shortness of breath. They can also have a palpable mass in the left lower quadrant, which represents the presence of a pseudocyst or an abscess formation. When we find a palpable mass anywhere in someone's abdomen, nursing only performs light palpation. This would be a huge contraindication to not perform deep palpation on these patients because you could rupture the mass, which is an abscess, so then that would lead to peritonitis. And then another assessment factor is Cullen sign or Turner sign, the results of a leaking of the pancreatic enzymes that actually reach the surface of the skin. So the top picture is Cullen sign, which is like a purplish color in their umbilicus. And then the next one is Turner sign. It says gray Turner sign. Gray is just describing the color. And this is Turner sign, and this is pancreatic enzymes that have leaked around their hips. So Cullen sign is in their belly button, Turner sign is around their hips, and that's the pancreatic enzymes leaking to the surface of the skin. Diagnostics. So with these patients, we have look at their serum amylase and serum lipase. Amylase goes up within 24 hours of the pancreatic injury, and it's the first to go up. It's also the first to go down. So if you have a patient that's being assessed to be discharged to home, amylase needs to be within normal limits, but the lipase may still be elevated. Lipase takes a while to come down. A CBC, we're looking for signs of infection, so we're looking at their white count and their neutrophils as well. CT scans, ultrasounds, and MRIs help confirm the inflammatory process around the pancreas. It'll also help identify if there's a pseudocyst or if they have some left lung pleural effusions. So the primary goal, pain management and comfort, nutritional management, and fluid balance. Think about what's the priority nursing goal. These patients are vomiting large amounts of emesis and they're not taking in fluid. They will become hypotensive and tachycardic, but yet they're still in pain. So can you give pain medication? Can you give a narcotic pain medication with patients that have hypotension and tachycardia? That's something that I want you to think about as we go through this process. So first of all, pharmacology. Narcotic pain medications. We do give narcotic pain medications, but they have to have a blood pressure and a heart rate to be able to support that narcotic pain medication. We'll also give antacids and H2 antagonists. What they do is, if your pancreas dumps the base into your GI system, so your stomach is responsible for the acids, your pancreas is responsible for the base, they equal each other out. If your pancreas is not producing the base, then there's too much acid. So we have to neutralize that acid in some way. So we'll take an antacid to neutralize it, or we may take an H2 antagonist to actually decrease the secretion production. Anticholinergics and antispasmodics, such as the bentyl and the probanthine that we spoke about in inflammatory bowel disease, also work here if pain is related to a spasm. And patients that have pancreatitis related to gallstones may get some of these probanthine and bentyl, because that gallstone is the reason that they have the pancreatitis. And if the gallstone's stuck, then the organ is trying to expel the stone and will have some cramping. Antiemetics, remember which antiemetics long-term use causes tardive dyskinesia, and that Phenergan actually increases decreases CNS and potentiates narcotics. So patients that are hypotensive and tachycardic may not be a candidate for Phenergan. Additionally, these patients may have some type of steroid treatment to decrease the immune function, to help decrease the inflammatory process. That's seen in patients who spend maybe 1 to 2 weeks in the hospital and still don't have any improvement in their pancreatitis. We give them a steroid to help decrease the inflammatory process. Interventions. So diet's a big deal for these patients. They actually have, anytime you put something in your mouth at all, your pancreas will start to produce amylase and lipase and try and spit it out into your duodenum. In these patients, the pancreas isn't spitting out amylase and lipase into the duodenum, but directly into the bloodstream and irritating the pancreas. So these patients are strict MPO. They can put nothing in their mouth whatsoever. They can't have ice chips, they can't have gum, they very often will have pain after they even brush their teeth. So they can't have any MPO. If they're MPO for more than a week and there's no resolution of pancreatitis, they may go on TPN. When they begin to start to heal, these patients will need high carbohydrate, high protein, and low fat diets. They're also going to want to avoid alcohol and caffeine, and they may need some fat-soluble supplements. Nursing nasogastric tube. So these patients will have a nasogastric tube, they'll have an NG tube. Think about all the nursing interventions related to the NG tube. I mean, patients can't lay flat because they're at risk for aspiration, so we need to sit the head of their bed at least 45 degrees. What fluid and electrolyte balances are they at risk for? What electrolyte would you think about replacing, etc.? How do you know that the tube is in the right place? We talk about evidence-based practice with placement of an NG tube. They have, we check pH is less than 5, or we do a chest x-ray. Using the swish of the air is not evidence-based practice. So remember all the interventions we talked about related to NG tubes. Potential complications. These patients can have peritonitis, they can have hypovolemic shock, they can have acute renal failure. Periods of hypotension cause renal failure. They can have a paralytic ileus because of all of the fluid and abscess material within their abdomen, or they can have DIC, disseminated intravascular coagulation. What's happened there is the pancreas the inflammation of the pancreas has actually traveled up the biliary tree and is now affecting the liver. So in the picture with the man with the Turner sign, you might have also noticed that he's jaundiced, because patients that have pancreatitis, have acute pancreatitis that's unresolved, the inflammation kind of spread up and can cause problems with their liver. We go back down, we think about left lung pleural effusions. Remember how we treat left lung pleural effusions. They can have a thoracentesis. They may have a chest tube. They're going to have, they may need oxygen. They may have to have LASIK. So all of those nursing interventions from oxygenation come over to this as well. So then chronic pancreatitis. We first talked about acute pancreatitis, now chronic pancreatitis. Patients that have chronic pancreatitis, it's from repeated episodes of alcohol exposure after the initial episode of acute pancreatitis. So if we have someone who is hospitalized with acute pancreatitis, they're a binge drinker, and they're given the instruction to quit drinking and to not binge drink anymore and to decrease their alcohol consumption, and they continue to use alcohol, they will be at risk for chronic pancreatitis. Chronic obstruction of the common bile duct. Some patients just are not surgical candidates to have their gallbladder taken out, and they continue to have biliary obstructions. That can cause chronic pancreatitis as well. Heredity, genetics, and autoimmune. There's a small percentage of patients where chronic pancreatitis is an autoimmune disorder. There's also chronic pancreatitis is seen in our cystic fibrosis patients because mucus plugs can get and clog the common bile duct, just like a gallstone would. Patients that have chronic pancreatitis, there are certain nursing interventions we have for them all the time, and some that are specifically related to when they have an exacerbation of the disease. So patients that have chronic pancreatitis will have episodes that resemble acute pancreatitis. So they'll have exacerbations of their disease, and then they'll have remissions of their disease, just like an autoimmune disorder does. So assessment, they have intense abdominal pain. They may actually have ascites from the pancreatitis, steatorrhea, so there's the lipase is not breaking down the fat, and they'll have extra fat in their stools. They could be jaundice because of the potential effects on the liver related to the chronic pancreatitis. And then polyuria, polydipsia, and polyphagia, they have signs and symptoms of diabetes. Basically, the whole pancreas is starting to fail at this point. These patients, the intense abdominal pain, and the ascites, are mostly seen in patients that are having exacerbations of the disease. The steatorrhea, the jaundice, and the signs and symptoms of diabetes are things that we'll see when they have them all the time. So diagnostics. They can have an ERCP. Remember what an ERCP is. To remove the stone. MRIs, CAT scans, and ultrasounds all help us determine how large the pancreas is, what other organs are involved, if they have pleural effusions or pseudocysts, or if there's liver damage, etc. The ultrasound is especially good for identifying fluid, so abscesses and pleural effusions. Abnormal glucose tolerance test, we'll do that to give a definite diagnosis of diabetes. Positive fecal fat and stool samples, because they're just not making enough lipase to break down the fat. And amylase and lipase values will be increased only if the patient is having an exacerbation of the disease. So these patients, a normal checkup for these patients, or a normal doctor's visit, even though they have chronic pancreatitis, if they're not having an exacerbation, their amylase and lipase will be normal. If they are having an exacerbation and they're hospitalized, their amylase and lipase will rise as well. So amylase and lipase rising is a sign of an acute process. So goals for these patients, they're going to have alterations in comfort, and we need to manage their endocrine and exocrine functions of their pancreas. Narcotics would be their pain management, and then enzyme replacement for their pancreatic function. There's pancreolase, which is Viocase or pancrease or Viocase. They take them when they eat. They help break down the sugars, the starches, and the fats. And how you would know they're working is that they don't have steatorrhea anymore, so that extra fat in their stool is gone. These patients may have to have insulin, ACHS. They may have to have a sliding scale. And just as we talked about with the acute pancreatitis, if their pancreas doesn't work, it doesn't make the base, they have more acid, they'll have periods of acid reflux and have GERD, and that'll be uncomfortable. So we give them histamine receptor antagonists such as Zantac. It's like a long-acting, long-term, instead of the H2 antagonist or the antacids. Surgical management. There's a lot of different things we can do surgically to help patients that have chronic pancreatitis. We may just need to take out their gallbladder. They may have to have a sphincterotomy. The sphincterotomy, it enlarges the pancreatic duct. If the sphincter has become fibrotic or doesn't stretch anymore, so we can make the pancreatic duct larger. The next one is considered a Whipple, where the pancreatic duct is opened and it's connected to the jejunum to relieve the obstruction. And they may have part of their pancreas actually removed due to advanced disease or disabling pain. They may actually remove part of the pancreas. Thank you.